Welcome to our P300 presentation by Dr. James W. Hall.
The P300 response was described first 45 years ago, roughly, and it was described independently by two different electrophysiology experts at the time. Both of them are shown in this slide. Most of you, as audiologists and people in the hearing business, so to speak, most of you are familiar with the name Hallowell Davis. I often refer to him as the father of auditory evoked responses. He was a remarkably productive man who really did conduct original research in every one of the evoked responses. We can thank Hallowell Davis, for example, for the acronym ABR and the phrase auditory brainstem response, which he coined in 1979. Hallowell Davis discovered components of the electrocochleography response, as well as co-discovering and developing some of the really good research on the late response and the middle latency. But here we're going to talk about his contributions in identifying the P300 response in the mid-1960s. Of course, Hallowell Davis, as you can see from his years here, had a very long life, died at the age of 96 in the year 1992. The fellow to the right, to be honest with you, I'd seen his picture many times. I thought he was actually older than he was, but Samuel Sutton, also in the mid-1960s, was conducting similar research on auditory evoked responses. He was not an audiologist or technically an auditory neurophysiologist or a otolaryngologist or hearing person. He was more of an electrophysiologist and died at a relatively young age, as you can see here. So they were both working independently on research that led to the discovery of the P300 response in the mid-1960s. Now, here's a figure from one of those original papers, and I'm going to take just a moment or two to explain what you're looking at. Some of you have seen this figure. I've included it in my book, and some of you may have read these original articles. You see waveforms in the figure. There's actually 5 sets of waveforms. You can see the analysis time along the bottom, 500 milliseconds. And it's very important to always look for an indicator of which is up and which is down. And in this case, the positive waves are plotted downward, and the negative waves are plotted upward. And that bar, that horizontal bar in the lower middle of the slide, shows 10 microvolts. So these are big responses. Now, at the top of the slide, you see sound 33%, and then toward the middle, you see a solid line indicating a certain response, or certain stimulus, rather, and a dashed line indicating an uncertain stimulus. What was done in these studies was subjects were, and each subject is identified by initials there, and looks like the date, looks like most of the data were collected in August of one of those years. Each time the person was presented with 2 sets of stimuli, a frequent stimulus, predictable stimulus, which they called certain, and then a rare, unpredictable, uncertain stimulus. They didn't know quite when they would hear it or how often they would hear it. And during this process, the subjects were reclining comfortably, and 2 responses were produced. The certain response, the frequent response, produced the traditional auditory late response. So I'm going to grab a little arrow here for the first time and come down and show you the late response. So here's the P200. This is 200 milliseconds down here. And this response is appearing in each of the certain waveforms, as you can see here. Now, what they were quite surprised to see, the investigators, was the uncertain response produced a separate peak, which, as you can see right here, and right here, very good examples, at around 300 milliseconds. And this response was very quickly described as the P300 because it was a peak in the response at 300 milliseconds. It's also sometimes referred to as a cognitive auditory evoked response. So that kind of got people interested in this obviously cortical response, and the research has continued since that time. Here's a drawing of the P300 response using the classic oddball paradigm for recording. And the oddball paradigm involves the infrequent response, which is shown down here. Let me grab my arrow again. The infrequent response, which can be any sound that differentiates from the frequent sound. So it could be a different frequency, could be da versus ga, could be a different duration, it could be a different intensity level. And the frequent response, which is predictable, perhaps being presented once every couple of seconds, produces, again, the traditional N1 and P2, the late response. But the infrequent, or sometimes referred to as the rare stimulus, which the person's listening to, produces not only the late response, the N1 and the P2, but also the very robust and much larger P3 or P300 response. And it is the third positive peak, so it's sometimes called P3. So this is called the oddball paradigm because there is an oddball stimulus that is attended by the listener. Now, you may be thinking at this point, well, sometimes we can't be sure that the listener is actually attending the stimulus, and so usually the subject or patient is asked to keep a tally of how many infrequent or rare stimuli they have, and the tester can monitor their attention to the rare stimulus by comparing how many stimuli they heard. Of course, we will always know how many stimuli the patients hear because the machine is keeping a track of that, and then we'll compare that number to how many the patient thinks they heard, and of course reinforce them for accurately listening. There have been some interesting studies on motivation and increasing the person's attention to the stimuli. Probably the most interesting for those of you who teach or those who might be students was a study conducted out at the Scripps Institute in La Jolla, California, beautiful La Jolla, where the researcher, John Pollack, had a bunch of students as subjects, and he told some of the students that they just needed to sit and listen to the tones, and that was pretty much it. Of course, some of them fell asleep, and some of them really didn't pay much attention. And then he had told another group of students that the accuracy with which they listened to the tones would determine their grade in the class. And if they are very accurate in listening for these rare signals, they would get an A, but if they weren't very accurate, their grade would be lower. And as you might imagine, that group produced enormous P3s throughout the study. So the amount of attention is one factor that will influence the size of the P3. Unfortunately, not all of our patients can attend to sounds. And if a patient has traumatic brain injury, if a patient has an attention deficit, they may very well have difficulty. And that led to research both at the Scripps Institute in California, but also in other places, including Europe and the Canary Islands, where Jose Barajas is located. Research on another form of P300 measurement called the passive paradigm. And here the patient's paying no attention to any of the stimuli. So, for example, they may be watching a silent cartoon or silent movie on a TV monitor or on a computer screen while these two different types of sounds are presented. And this can even be recorded from a younger child who can't really be instructed to listen to sound. They just need to not listen to the sound. And as you can see here, I'll get my arrow again, the P3 actually moves in a little shorter in latency, and it's reduced in amplitude. It's sometimes referred to as the P3A. So that's a passive P300, which has been reported, but really I don't think has been fully exploited clinically. It may have more potential, mainly because of the advantage of not having the patient have to attend to the novel or rare stimulus. Now, where do these responses come from? Well, as you look at this slide, they're very high in the auditory system, certainly above the level of the brain stem. perhaps involving the thalamus, but probably most likely originate from the cortex. So it's a very late response, a high-level response, a response that actually gets closer to auditory processing as we normally think about it in the clinic. Now, the P300 does not arise from a single generator. It has multiple generators throughout the auditory cortex. And there's considerable evidence that the P300 response arises not just from the traditional auditory cortex, the part of the temporal lobe, the top part of the temporal lobe, the secondary auditory areas, but also from the limbic system. There have been some excellent articles, some of them dating back 20 years, which involve neurosurgeons inserting in a human brain a needle that passes down through the cortical areas and other parts of the cerebrum into the limbic system structures around the hippocampus and the amygdala. And these studies have shown a large peak at P300, at the 300 millisecond region with the rare stimulus arising from these structures. And then as the needle passes through this region, this peak inverts, which usually is identifying the actual generator. Well, this is very interesting because if the limbic system and the emotional parts of the brain and some of the attention parts of the brain are involved, then that may explain why attention is so important in producing a large P300, and it may also offer some potential applications of the P300 in some of the patients that we really could be evaluating. For example, veterans who have been exposed to combat injuries, traumatic brain injuries, and might even have post-traumatic stress disorder, all of which is can be mediated in this region. So the literature on the generators of the P300 from 20 years ago still might be very applicable to some of our patient populations today. Okay, now I'd like to take a few minutes to review the test protocol for the P300. And we're going to talk about stimulus parameters first and then acquisition parameters. In the early years, this is kind of ironic, of evoked response applications by audiologists, and so I'm talking the 1980s, many of the manufacturers, including Biologic, immediately came out with a P300 option, which allows you to present two stimuli during the same test session, the rare and the frequent, and then to analyze the response to each of these stimuli. Now, obviously, you can't do that with every evoked response system. You certainly can't do that with most evoked response systems that don't have a P300 option. And the irony really is that back in the 80s, almost all of the manufacturers offered the P300 option. But over the years, for a variety of reasons, maybe cost, maybe perception that people weren't using it or asking for it, most of the manufacturers had dropped this. But it is still available on the Biologic NAV Pro and can be implemented very, very simply, much like you would set up an ABR or a middle latency response. So the stimulus is never a click, always a tone, or it could be a speech signal. And we'll talk more about that toward the end. If it is a tone, there has to be a difference in frequency between the frequent stimulus or the predictable stimulus and the rare stimulus. And it can be a long duration tone. With any of the late responses, we can have plateaus that are quite long, and as you can see here, it could be 30 milliseconds or even longer, and a reasonably leisurely rise-fall time as well. The rate must be slow, and actually the slower the better. So the amplitude will increase if the stimulus rate is slowed down to 1 every 3 or 4 or even 5 seconds. This is a very slow response involving the dendrites and the cortex, so it takes a while for these neurons to get ready for the next stimulus. The problem, of course, with a very slow rate is the test time is increased, and there's more opportunity for the patient to move and introduce some artifact. So a rate of less than 1 per second, but probably no slower than 1 every 5 seconds would be optimal. We don't care much about the polarities. We won't talk about that. We typically will use a moderate intensity, not too high, not too low. And then, of course, we need to decide which kind of stimulus will be used for the frequent and which for the rare, or the oddball stimulus. And the difference can really be any acoustic difference. For the P300 response, we want that difference to be relatively large. In other words, we want a difference in frequency of, for example, 500 and 2,000, or 1,000 and 2,000 hertz, easily distinguished, not a couple of hertz. But again, it doesn't have to be a frequency difference. It could be two different speech sounds, two different durations. Really, any change in acoustic change between the two stimuli. Now, the probability that the rare stimulus will actually occur should be around 20%. In other words, out of 100 stimuli, roughly 20 of them should be the rare stimuli and the other 80 frequent. And that's been studied pretty well. If you decrease the probability too far below 20%, the patient begins to lose interest and think that, well, there's probably not going to be any more stimuli, and they stop listening. But if the probability creeps up and gets toward 50%, well, then, of course, the rare stimulus is not rare anymore. The rare and the frequent stimuli are equally probable of being heard. So this is set with the equipment, and I'll show you how it's done on the screen in just a moment. But the rare stimulus should be reasonably rare, and it's really not totally random. The term pseudo-random is often used to describe the probability. That means it's 20%, but there are some exceptions. The very first stimulus presented can't be a rare stimulus because, of course, it would be perceived as the frequent, and you can't have two rare stimuli presented together in the presentation. So that would happen if it were purely random every now and then. The repetitions don't have to be that great. Now, this is a big response, 10 microvolts or larger. So you can easily see a good P300 coming in with less than 200 stimuli, rare stimuli. And my approach is usually to record 3 or sometimes even 4 waveforms, maybe each with 100 stimuli, 150, and then adding them together rather than presenting 400 or 500 rare stimuli and then stopping. And if you add them together, you can assess replicability, and you can also discard any averages, any waveforms where the patient moved a little bit or there was some artifact for some reason. Okay, continuing on with the test protocol, we'll now look at the acquisition parameters, and these are, for the most part, are just about what you'd use for the late response, which makes sense. We're actually recording a late response as we record P300. So we use a long analysis time. We typically want the peaks that we're recording to be in the middle of the analysis time, whether it's an ABR or any other response. So here, the peak is at 300 milliseconds, so a good analysis time is 600 milliseconds. Now, most audiologists don't use a pre-stimulus analysis time, which is unfortunate. Even Jewett and Williston, the very first ABR paper, had a nice, long pre-stimulus time. So I'd encourage you to do that. And with any of the evoked response systems, you can easily select a time where you start averaging before the stimulus is presented. So for this response, which has a long analysis time, you could use a pre-stimulus time of either 100 or even longer. An advantage of that is that if you're averaging and the conditions are good, the test conditions, the pre-stimulus baseline should be relatively flat, and then all of the responses after, or the peaks after the stimulus, can be considered responses. If, on the other hand, in the pre-stimulus condition, you're seeing peaks and valleys that represent a response, well, they obviously can't be, it's pre-stimulus, then that's a clue for you to improve the test conditions. The patient's either developing myogenic artifact, or you're picking up electrical artifact, or perhaps there's something else happening, like the patient's blinking their eyes regularly, and that's what you're actually recording. So the pre-stimulus baseline has value. The electrodes can be in many different places. Some people record P300 using experimental equipment, using 30 electrodes. But traditionally, over the years, a midline electrode has been used for the non-inverting electrode location. And it can be on the vertex and CZ, could be FC, which is where you would normally put the non-inverting electrode for ABR, which makes it convenient, or maybe somewhere else along the midline. The earlobe electrode, or I should say inverting electrodes, can be on the earlobes. They can be linked with a little connector cable, or you could use a non-cephalic inverting electrode like the nape of the neck, the top of the neck, the base of the skull. Now, it's very important when you're recording the P300 to have at least one electrode located at the corner of the eye, because if an eye blink will produce a large muscle response, which could be mistakenly confused for a P300. And you may run into a patient every now and then who gets in the habit of blinking their eye every time they hear a rare stimulus. And that would contaminate your results, and you could easily be analyzing a myogenic response and not the response you're interested in. Amplification doesn't have to be very big. It's nothing like ABR because this is a big response. The signal-to-noise ratio will naturally be larger because the response is larger. And then you're going to need to have a channel to record the actual response for the frequent stimulus as well as the rare stimulus. So that's kind of the unique feature of the P300 software. The filter settings are as they would be for a late response, where you're emphasizing the low frequencies. It's a very low frequency response. If a response is occurring every 100 milliseconds, it's only occurring about 10 times per second. So the 10 hertz is a very low frequency relative to, say, the ABR. And, of course, we don't want the notch filter. That might actually filter out part of the response, so we turn that off. Now, I'm going to take a moment to show you how you would actually set this up with biological equipment. You want to get into the screen where you actually can develop protocols. And so what we have here is get my little marker again, is a captured screen where it's a collection protocol setup. Now, you have to select P300 protocol, otherwise you won't have some of the options we'll be talking about here. And so here, as you can see, we can set the epoch or the analysis time. Here it's 533 milliseconds, but it could be shorter or longer. Here we're selecting how many data points. And this is a slow response, so 512 data points over that analysis time is fine. You could use 1,024 if you wanted to, either one. Here we've got the pre-stimulus baseline, pre-post stimulus. So you can actually show that here is where you would set up the pre-stimulus baseline. I would not recommend any blocking. We don't really need that. There's not going to be any stimulus artifact. We're far away from the stimulus, so that's not necessary. And here's the maximum number of infrequent or rare averages. And so you could set this to a higher number, maybe 200, and then stop the averaging as soon as the response was there, or you could set it at 50 and get 3 or 4 averages at 50 and add them all together, and then you'd have a summed waveform that would be quite stable. Moving on real quickly here, we want to make sure that we leave at least 10 minutes for questions at the end. We're still setting up the protocol, but now right here we're working on the amplifier parameters. And so here's the gain, and as I said, it doesn't have to be as high as it would be for a smaller response like the ABR. So 50,000 or even 25,000 would be adequate. The filter settings are set here. Now, bear in mind that the term low filter really means a high-pass filter setting. And so that can be 1 hertz or even as low as 0.1 hertz. And then the high filter is really the low-pass filter, and that would be no higher than 100 hertz, could even be a little lower. No notch filter, notice that, so we don't want to enable the notch filter because that would filter out frequencies where the response is actually being recorded. Here you have the electrode locations. The non-inverting electrode in this case is CZ, and the inverting electrode is the ipsilateral earlobe, and that's not atypical. I'm going to move on to the next screen. And now, as you'll see here, we're selecting stimulus parameters. Now, this is where the screen looks quite a bit different for P300 than it would for, say, the ABR or even any other cortical response. Here we're using insert earphones in the right ear, where some of these things we don't change. We're using Blackman rise fall time shaping, which is very appropriate. Here's the stimulus rate per second. And so we might slow this down a little bit. We might want to put 0.1 here, so we'd have a, or 0.5 rather, so we'd have a stimulus every other second, or 0.2, so we'd have a stimulus every 5 seconds. But here's the real important part: frequency ratio. And this may not be all that intuitive. It says 5. So that means the ratio of the frequent to infrequent is 5 to 1, which would be 20%. So don't set this for number to 20 thinking it's a 20%, because then you'd have a frequent-infrequent ratio that's much, much smaller. It would be 5%, and you wouldn't want that. You notice here we've got the term pseudo-random stimulation, which is what we want, 5 dB intensity increments. And then down here, we're going to make two selections. We're going to first select the frequent stimulus. In this case, it's a 70 dB tone at 1,000 hertz. And you can see that the rise-fall is 10 milliseconds, and in this case, the plateau is 30 milliseconds, which is fine. Now, you can't stop here. We're going to have to go to another screen, and we're going to have to set the parameters for the infrequent stimulus. So let's do that next. Okay, everything else is the same here, except now we're setting the parameters for the infrequent stimulus. So still a rarefaction polarity. It's 70 dB still, and we want to keep all of the parameters the same except the one acoustic difference between the stimuli. And in this case, it's 2,000 hertz instead of 1,000 hertz. Now, let me just quickly point out at this point that if you're evaluating a patient with P300, always have an audiogram first. And if you're in a VA setting, or if you're evaluating patients who might be elderly and have presbycusis, or might have also noise-induced hearing loss, let's say a veteran who was exposed to a blast injury and has considerable high-frequency hearing loss as well as traumatic brain injury, you can select the frequent and infrequent to avoid the area of hearing loss. In fact, you should do that. Just imagine for a moment that you have a patient with a very, very precipitous high-frequency hearing loss, but you don't know that. You don't think about it. So you select a frequent stimulus of 500 and a rare stimulus of 2,000. Unfortunately, the hearing is not the same at 500 and 2,000 hertz on the audiogram. You could very well not record a P300 because the patient wasn't hearing the response, the stimulus. So if you've got a patient with a high-frequency hearing loss, it would be very appropriate to use two lower frequency stimuli, different but low frequency, to record that response. And of course, you really should have a rise, fall, and plateau that are exactly the same, although you could make that the difference. You could have a frequent and infrequent stimulus that were the same frequency, same intensity, but the big difference was the duration, and that might be a very useful measure of auditory processing in a patient who might have an auditory processing disorder. All right, here's an example recorded with a biologic of a P300. Normally, this would be a summed example, but normally we would want to have, let me get my arrow here again. Normally, we would want to replicate or triplicate or quadruplicate, if that's a word. But you can see there's a response coming in right around 300 milliseconds in the infrequent channel, which is indicated over here, infrequent, and then the frequent channel showing the traditional P2 response. And sometimes they look clearer than this, and of course we would want the replication. All right. Now, the issue always comes up, or a question often comes up, well, wait a minute. You've got two stimuli, frequent and infrequent. Isn't this the same as recording a mismatched negativity response? What's the difference between a mismatched negativity response and P300? And if you're going to record this passive P300, what do you have to do differently in recording it? So we're going to address each of these two questions. First, we have the different recording strategies that can be used for the P300. We've already mentioned the passive P300, and that's described right here. So basically, the patient is not required to listen to the stimuli. In fact, they're encouraged by focusing on a visual stimulus, for example, not to listen to either. And we're going to expect that the passive P300 is earlier in latency and smaller in amplitude. And there have been many clever ways of doing this, some of which only involve a rare stimulus, believe it or not. If there is no frequent stimulus, but the rare stimulus is unpredictable, the person you can still generate a P300 with just this one stimulus. And then there are more complicated paradigms which involve two or three stimuli, and the patient's going to be focusing on just one of those multiple stimuli. So what I've described here is a very simple way of recording P300, but understand that there are ways of assessing cognitive function that are a little more complicated and a little more interesting that have been reported in the literature. In fact, the literature on P300 is huge. When I was researching for my latest, the new handbook of auditory evoked responses, I just tell you a quick story. I had a teaching assistant, a graduate assistant, who was helping me find the articles. And so I said, well, what I want you to do is just go through the years since the first book, so starting out with 1990, 1991, and just go through the years and do a Medline search and just look for P300 auditory articles. So send them to me when you send all the abstracts of these articles to me, and then I'll look through the abstracts and decide which articles I want to read. So I get an email, and it's got an attachment, and I say, oh, good, it's about 9 o'clock at night, and I've had dinner. I'll just sit down and review a few of these articles. There's probably just going to be a couple of them. It was only for 1 year, like 1994. And I open up this attachment, and there were about 400 articles on P300 that had come in that 1 year. And there are thousands and thousands of articles on the P300. Almost all of them, I mean, probably 95% are being written by psychiatrists, neurologists, electrophysiologists, and described for patient populations that we would not normally see. So there's enormous literature on the P300. What I'm describing today is just kind of the bread and butter, simple way of recording the response. All right, now I've mentioned this difference between the P300 mismatch negativity response, and here we have the main differences. This is from a table in the book. The P300 response does require attention to the rare stimulus. It's going to use the classic oddball paradigm. The P300 response amplitude is directly related to subject attention. So you remember those students who thought their grades were going to be dependent on the whether or not they had a P300 or how big it was. They had really big responses. The response amplitude is related to task and task relevance. So the more meaningful the task to the patient, the larger the response. Back many years ago, back in the 80s, I was doing quite a bit of work in the intensive care unit, the neurointensive care unit with head injured patients, and we were recording P300 from head injured patients. We found that the traditional tonal difference, 1,000 hertz tone and 500, it might not elicit much of a response. Now, our goal was to try to predict cognitive outcome in these patients, and we presume, based on the literature and our experience, that if the patient had a P300 response, even if they were comatose, that would be a very good sign. But some of these patients just didn't have much of a response, so the neurosurgeon I was working with said, hey, I know somebody out in California who has been eliciting a P300 with novel stimuli, like dogs barking. So we got a tape from this person, and it was a little yappy type dog with a small bark, and that still didn't give us much of a P300. So then this neurosurgeon said, well, I've got a better idea. I've got a German Shepherd. I'll get my dog all riled up, and I'll tape record some of the barking. And we actually got a huge P300 from this poor patient who had this dog barking in their ear. So task relevance and the task itself will have a big effect on the response. Of course, the mismatch negativity has a latency, the P300 of about 300 milliseconds. Generators are in the auditory cortex and limbic system. And the bigger the difference between the rare and the frequent stimulus, the bigger the P300. So let's just look at the mismatch negativity now. Well, this involves a pre-perceptual detection of a change. So you can have a sleeping patient and they'll still produce a mismatch negativity. It's a subconscious detection by the brain of a mismatch in the stimulus. And the amplitude of of the response doesn't have anything to do with whether the patient's attending to the deviant stimuli, nor does it have anything to do with task relevance or stimulus relevance. The latency of the P300 is actually before 300 milliseconds. It's usually within a range of 100 to 300 milliseconds, so that's a big difference. And the mismatch negativity involves frontal lobe contributions, not just auditory. And then finally, and this is one of the biggest distinctions between the P300 mismatch negativity, the smaller the difference between the standard and the rare, or sometimes called deviant stimuli for P300, produces actually the best mismatch negativity, whereas it would actually produce a very small or no P300. So this is one way that we can actually distinguish the two when we're recording. Okay, I'm mindful of the time. I have 11:39 on my clock, my computer. Some of the factors influencing the latency and amplitude of the P300, we've already talked about some of them, but very briefly, I'll mention a few more here. I've already mentioned the probability. So the less probable the stimulus, the shorter the latency and the larger the amplitude, which is a more robust response. Attention, obviously, more attention, greater amplitude, shorter latency. You can record a P300 response from people across the age spectrum, but there is an age maturation effect. The latency decreases in children up to about the age of 19 or 20, and then, unfortunately, we're over the hill after that. As I look at some of the names here of the people attending this, you're definitely past 20 years old. Some of you are nearing retirement. So your P300 latency has been increasing for years and years. It is a measure of cognitive function, and we know that cognitive function does decline really through much of the lifespan, but certainly above the age of 40 or 50. No gender effect, really not much of a handedness effect. Sleep does influence the response tremendously, and I already talked about difficulty of the task. And anything that affects memory will affect the latency of the P300. In fact, there's research showing that you can actually document the effectiveness of drugs that are designed to improve memory by monitoring the P300. Okay, I'm going to finish up my lecture by talking about a few of the applications. One of the very first applications of P300 in clinical audiology was by this fellow, Bob Jerza, who unfortunately died quite young in the age of, in 2009. This is Bob over on the left, and you can see the slide on the right, figure on the right actually shows him doing some recordings of someone in Connecticut where he was a professor at Southern Connecticut State University. Bob, I'm going to just quickly show you some of his work because it really was the first in audiology. He was among the first to show the P300 could be used to document auditory processing abnormality in APD, known as CAPD also. So what you can see here is the traditional P2 response, the late response, N1, and then the P3 in a group of normal subjects. And the P300 response, it's a little late. It's coming in about probably 350 milliseconds, but that's okay. It depends on the stimulus parameters, et cetera. But notice the group of patients with CAPD have incredibly delayed responses. Well, Bob Jerza conducted further studies, and he actually, these are some of his articles. I'm just showing you here. Whoops, went a little too fast. And what he found was that actually not only could you document auditory processing disorders with P300, but you could actually document the benefits of therapy or intervention. In other words, the response latency got shorter with effective intervention, and that really opened the door to a whole new application of auditory responses that people like Frank Music and Nina Krause have followed since then. But it was really Bob that first described that finding with P300. I've collected some data over the years as well, and this is back in the mid-1990s when I was at Vanderbilt. We were looking at electrophysiologic measures in patients with APD, mostly children, and you can see here, here's P300 over on the far right, and that somewhere between 40 and 50% of a consecutive series of children or patients with APD actually had abnormal P300. And it was the most sensitive measure. You can see the reflexes and ABR, and even the middle latency response and late response weren't quite as sensitive to APD. So this is a way of documenting, electrophysiologically documenting auditory processing disorder. You wouldn't expect the abnormalities in all patients, but certainly they can be recorded in some. Very quickly, I'll point you in the direction of the clinical guidelines for APD developed, reported first in August of 2010, about a year and a half ago. And this is the cover of the document. You can download it easily from the AAA website. The P300 is addressed in this document. And this document summarizes evidence in support of different auditory assessments of the APD. And so here are some of the quotes from the document citing actual literature that confirms the use of P300 in the evaluation of the central auditory nervous system, including the assessment of auditory processing disorder. So obviously, we should be always practicing audiology using best practices and according to research evidence, and there is some research evidence in support of the use of P300. The same document also identifies some research needs, as you can see here, and there is a need for large-scale studies, more normative data, and a systematic investigation of the correlation between behavioral responses or behavioral findings for APD tests and electrophysiologic tests in the same group of people. Okay, I'm going to wrap up my lecture by pointing out that one big application of P300, certainly a potential application, is in the objective assessment of veterans and military personnel with traumatic brain injury. And this is a top priority in the VA. There is research underway now, both at the Research Center in Portland, Oregon, and also Walter Reed Army Medical Center, or that facility, now it's at Bethesda, on this application of all auditory processing measures. One big advantage, though, of P300 over the behavioral test is that it is objective, and it's not going to be influenced tremendously by some of the factors that can influence behavioral tests. Many of these patients with TBI are going to have cognitive deficits, language deficits, and other problems that might influence their behavioral test results, and we can circumvent these limitations of the behavioral test by using a procedure such as P300. I'm just going to quickly go to this slide. This is one of the learning objectives. P300 has been reported in many clinical populations. As I mentioned earlier, most of them, we would not even encounter these patients. It's been recorded, for example, in patients with brain cerebral deficits due to chronic alcoholism, dementia, including Alzheimer's dementia, which, by the way, is often associated with auditory deficits. In fact, auditory processing deficits are one of the first findings in Alzheimer's dementia. There are studies of P300 in stroke, attention deficit hyperactivity disorder, and now getting into an auditory region, so it's highlighted, auditory processing disorders, as we discussed with Bob Jers's studies. Schizophrenia is one of the more common patient populations that's been studied with P300. There are literally hundreds and hundreds of articles. Also language impairment and learning disability. And of course we can use speech stimuli to elicit the P300. So there's an option here for an objective assessment of how a child is processing speech stimuli, and of course a traumatic brain injury, as I've already mentioned. So this is the next to the last slide. We've got this response that's been with us for 45 years, and yet if we were to survey all the audiologists in the United States, let's say, we'd probably find that a handful actually use P300 on a regular basis. So how can we improve the clinical applicability of this response? How can we make it more popular as a diagnostic measure? Because it certainly has some advantages. Well, we could start with development of a evidence-based accepted test protocol. So we know exactly how to record it, and everybody would be using essentially the same protocol. And that's certainly already been done for the ABR, and it could easily be done for P300. We need, obviously, clinical equipment, FDA approved, that has the P300 option. As I said earlier, we've taken a step back there. Many systems don't have the P300 option anymore. And so the only people that can actually record it very often are people in the laboratory using expensive, complicated laboratory instrumentation that's not designed for the clinic. So that's really a manufacturer challenge. We need to have multiple channels. We've taken a step back here, too. It used to be that you could easily buy an ABR system or an evoked response system with 4 channels, and now sometimes you can barely get 2. And we really need more than 2 channels to record a P300, because we do need to have at least a channel for eye blink electrodes plus the auditory. And we need protocols that involve more complex stimulus parameters. Speech and noise, we've done that before. You can present a stimulus for the P300 in the presence of background noise, or maybe a gap detection type protocol where the P300 is actually elicited by a gap in the sound rather than an actual sound. We need statistical analysis of the response, kind of the biomark approach. Some of you are familiar with that, where it's automated and it's based on large collection of good normative data rather than each audiologist trying to analyze the waveforms subjectively. And, of course, we need normative data because we know there's an age effect, and we know that that needs to be taken into account in our analysis. So I think with a combination of manufacturer cooperation and some research input, some good clinical trials, the P300 could easily become a routine procedure for those people who are interested in evaluating higher-level auditory functioning. So I've come to the end of my lecture. It's 11:50, so we have 10 minutes. So I'm going to turn it back over to Mary